Good morning, everyone. My name is Thomas Goffrey, and we're delighted to welcome you to our Putting Public Health Evidence into Action series. And we're going to continue with adapting evidence-based interventions this morning. This is module 4 in a series, as you've seen, and we're delighted that you have joined us in other series, are continuing, and for those of you who are new, who are joining us. We do have this training as part of our CPCRN Scholars program. So if you are a scholar attending, could you just please add your name in the chat so that we could just see that you're actually registering and attending today. So thank you so much for doing that. It is my pleasure to continue on with the training. And we have started at the very top with Mary Wiegand presenting Understanding the Problem and Establishing Goals for Improvement. Then we had Dr. Jennifer Lehman talking about finding and selecting evidence-based interventions. And then today, we're going to spend the next hour talking about adapting evidence-based interventions. And it's great to see so many people joining us on a Friday to learn about program adaptation. So here are our objectives for this module. This is an area that I'm really interested in, and I know a lot of people have questions in practice. So the objectives are to define adaptation, fidelity, and core elements of programs, describe common steps and processes for program adaptation, and discuss what changes can be made without affecting the effectiveness of the program and what changes you probably shouldn't make. I invite you, we will have some interactivity at a few points in this training, but I also invite you to put your questions in the chat, and then at the end, we could take your questions. So thanks so much for just putting them in now as we go along, and also having your questions at the end. So the first thing we often want to do is to think about terminology. So what is program adaptation? Many of you have heard different definitions. Program adaptation is making changes or modifications to a program or strategy to better fit priority populations and local conditions or contexts. We also wanted to highlight that in doing intervention planning for cancer control, which many of us work in, or just health promotion or public health, we can address health equity by adapting evidence-based programs for different contexts. So the whole idea of program adaptation is you could take a package evidence-based program and change it with a very systematic step, meaning program adaptation, to be able to fit a potentially evidence-based program to a different population. So it may have been originally developed for Latinos, and you will try to adapt it for a different population, say African-American women. Common types of adaptations are what you see across the bottom. You could be making additions, hopefully a few, to the program. You may be trying to delete elements of the program or adding other components or elements, which are called substitutions. So this is the big question that we often have, is when you're making adaptations, you're trying to make it a lot more compatible and fit with your population or context. So we're trying to achieve high fit, but since you are working with an original program, you also have to balance the fit with trying to implement the evidence-based intervention as it was originally proscribed or prescribed in the original protocol, which is basically the how to do the intervention. So that's the tension that we often call fidelity and fit considerations. And some of the things that we're going to be talking about today will kind of help you with some of the consideration and also give you guidance in achieving the best balance. So the million-dollar question is, how do we think about addressing fit and also maintaining fidelity? One of the core ways is to examine what are the core elements of a program. And this means how the program was actually developed. So what were the required components based on the logical mechanisms of change? These might be your theory strategies. And what are the key delivery steps? They also probably likely help achieve the evidence-based program or interventions effectiveness. So my easy analogy is on the right, is core elements are typically called the core ingredients of the recipe of the program. So the recipe might tell you what to include. So if you think about recipes, these are all the ingredients. It will tell you actually how to do it. So that would be the delivery mechanisms and methods. So the step-by-step guide for how to mix or blend or cook ingredients. So these are the core elements of a program. The challenge in our field is that core elements is a newer term. And so programs may not always identify core elements. And so you have to really read about them in either the program manual and or articles to understand the core elements. If programs are being disseminated widely, the intervention manuals, if they're more recent, probably will help you identify what are these core elements or core ingredients. Another lens of looking at core elements is kind of a new framework of forms versus function. And I wanted to kind of go over that today. So the function of an intervention element is the rationale for doing the activity. These rationales are often related to their theoretical strategies. So if you're using a theoretical strategy of helping them increase knowledge, that is a core function within an intervention program. So we might be trying to increase knowledge of, for example, cancer screening or HPV vaccination. And that's one of our core elements that we're trying to incorporate in the program. So that's function versus forms. Forms basically are different activities of the evidence-based intervention. And they might be things that we could change based on the content, such as how might we deliver it differently when you're making adaptations for a new setting? How might the implementer change or deliverer change? It could have been a community health worker in one intervention, and in your new settings, you might not have access to community health workers, but you might have health educators or social workers to actually deliver the intervention. So another example of this, if you're trying to have an element to increase self-efficacy in a couple of different theories that you have in a program, your forms in the original program could have been watching a video. But in your new setting, you may not actually have access to technology, or you might be in a lower resource setting. So somebody can actually act out that particular skill that you're asking them to learn, so that it could be a live performance versus watching a video that requires some technology. So again, forms are things that can be changed as you are looking from the original program to your new program. So this is another take on core elements that you actually might see in the field. So the next area is helping you to think about what are common ways that people approach program adaptation. This was a scoping study that I did with some colleagues around adaptation frameworks. And as you know, frameworks are just articles that are helping us design steps, in this case, around product adaptation. And so we looked both at what we call the gray literature published reports, and we also looked at articles in the research literature, and we examined what were adaptation frameworks out there. If you're interested in any of these, you can certainly go to the article or actually just Google any one of these different adaptation models. And these might be actually helpful if you're looking through steps in conducting adaptation. So you'll see the great literature examples here are the Center for Substance Abuse Prevention Guidelines for Balancing Program Fidelity and Adaptations, all the way through intervention mapping, which is the program planning model. And on the right, you'll see examples of some of the published adaptation frameworks that are in the literature, map of the adaptation process. The fourth one, adapted, is very commonly used. And then there's some that are specific to cultural adaptation that you could see in the article as well. But to actually make it easier for you, we actually catalog across all those 13 frameworks, what are the common steps? And so you see here the 11 common steps that were across all these frameworks. And again, this is a range of the steps. So being able to understand the community that you're working with, also reading and learning about the evidence-based interventions, or if you have multiple evidence-based interventions that you're trying to choose for adaptation, understanding those, and then selecting the intervention that you want to either adopt, or in this case, make adaptations to. Consultation and co-learning is very important. So we have consultation with experts who might know the audience, know the disease topic area, cancer prevention and control, obesity, and also work with stakeholders. And a lot of times these might be members of your primary audience. Having done those consultations, you will decide what needs to be adapted and make adaptations. The next two steps are critical in terms of ensuring that the program gets delivered correctly. It's training staff on the adaptation. You might want to pilot test some of the adaptive materials, and then, of course, implement the full adaptive program and conduct the evaluation. What we found is across these range of steps, 8 of these steps were very common across 5 or more of the frameworks. And you can kind of see the numbers there, from assessing the community to selecting the interventions, deciding what needs to be adapted, and then making the adaptations, and then testing it all the way through evaluation. So if you're looking for critical steps in adaptations, I think these would be the ones that you can cite and follow through the process. We're actually going to share in a few minutes a condensed version of this and walk you through the process. So this is our condensed version, is a 5-step process using some of the literature, as we just said. So the steps for adaptation we're going to walk you through today are assessing fit. So that means trying to understand what needs to be changed based on the program, and also knowing your new context for the adaptation. Then decide what needs to be adapted, which is step 2. Step 3, make the adaptations. Step 4, pretest the adaptations. And step 5, conducting a pilot test. So let's go through assessing fit. This table might be very familiar. We often talk about understanding the intervention. And in last session, we talked about looking at the program and the program comparison tool. So this should be very familiar with to you for this process. But if not, I'll kind of, and it's new to you, I'll walk through the process here. So oftentimes in understanding a program, we look at areas on the first column. What is the health problem? What are the objectives of the program? Who is the primary population that the program was developed for? What is the setting? What are determinants? What are the resources needed to do all of the core elements? So those are fit criterion. And then often as Mary talked about, you need to understand your new setting or your new population. So that's where I would fill in the column of assessment finding. This is the program adaptation community that you want to work with. Then you're going to describe your selected intervention and fill in the column there for all of the selected intervention points. And then you're going to do a critical review of, does this particular evidence-based intervention fit with your population that you described in the assessment finding? And we made it really simple: yes, maybe, or no. So you're going to have that kind of discussion with your planning team or program planning team. Then once you have done that analysis, you're going to think about if it's yes or maybe, thinking about what needs to be changed. What are areas of misalignment from the original evidence-based intervention to your particular target population, and start to fill this out. And as I said, these are great tools that you could actually use or mimic with your planning team and have some discussion around. So it's not just one person making some of the decision. So for instance, you might be having a change to the priority population and having to think about, what does that mean in terms of change of content, maybe even change to your delivery mechanism, if they may not have access to technology, for example. You might also look at the setting to see if the setting for your target population might need to shift from the original setting. So a group-based intervention, an evidence-based group-based intervention, can be delivered in different settings as long as you can get your participants there with ease. And they also fit with perhaps the criterion or eligibility requirements of the original program. So those are some of the things that you are thinking about. And then in the last column, you would actually write what things need to be adapted. So again, if the priority population of the first evidence-based intervention in the third column is different from your new population or the adapted community, then you would actually make all of the notations here and have some discussions about that. To help with thinking through what you should be changing and what probably should not be changing, we use an adapted model from the Promoting Science-Based Approaches to Teen Pregnancy. And this is a analogy to a stoplight that we use for this particular analysis. So you will see that red light considerations are things that you shouldn't make changes to from the original program because they might be really core elements or core forms or core functions of the program, that we had talked about before. Yellow light adaptations could be made, but you might have to proceed with caution. You might have to do more pilot testing or consultation with experts to make sure that you're doing it correctly. And then green light adaptations are safe. So let's get into like the nuts and bolts of each one of these, and I think it will make sense to you. So for red light adaptations, these are adaptations that typically are related to the theory or the evidence-based mechanism of change. So as I talked about before, these could be things related to theory-based strategies such as modeling, increasing knowledge, changing the environment. And if these are noted as core elements, you do not want to make these changes. And sometimes in intervention manuals, they actually tell you what these components are. So these could be things like not changing the topic or health behaviors, or sometimes adding another health behaviors. It could also be adding activities that contradict or detract from the original goals of programs. I've seen this happen sometimes in my adaptation kind of study where communities get really excited about public health programs, and then they have this package program, but they want to add more to it that can really be changing the objectives or also detracting from the original activities. Of course, the next one makes sense, not deleting whole sections or major activities. So if you have a 6-session program, of course you want to, in terms of time or limitations, your team might be considering, let's make it 4 sessions, but you may not be able to do that because you're actually deleting some core topics that were mentioned. And the same thing with reducing maybe the time or durations of sessions just because of constraints. If you don't really can't cover all of the intended topics. So those are things that we know that we should not be making changes for. On the other hand, yellow light adaptations are things that we can consider and maybe change with caution, and probably go to your planning team and maybe some experts to help with that. So these typical changes are making changes to the content or methods. So we talked about these, or might be examples of the methods being forms. Altering the length of program activity as long as you are covering some of the main areas. Maybe changing the order of sessions. So you're still covering all the topics, but some of the ordering is shifted slightly. Adding an activity might be okay if you're trying to cover other activities or risk factors or behaviors. And of course, applying evidence-based interventions to different populations. You can also consider changing delivery mechanisms. We talked about changing implementers before. So it might be changing the format of something that was web-based to a mobile app, because you can deliver the same information just on a different technology platform. We talked about considering who the delivery people are based on your setting. Who can you train to also deliver the same knowledge? Who can also do the same facilitation from one setting to another? That typically is okay if you have some training for them. And substituting activities or materials might also be okay if it's not, again, some of the critical elements. Finally, green light are adaptations that typically are easier changes to make. For some of you that follow the adaptation literature, these are what we would call surface or level or minor adaptations to increase either reach, receptivity to your new population and to participation. So of course, depending on when programs were developed, you might be updating statistics and guidelines. So for example, in cancer screening, the area that I work in, a lot of times screening guidelines need to be updated if the program is more than 3 to 5 years old, because cancer screening guidelines in terms of mammography frequency or age criteria may have changed since the original program was developed. You may also be customizing areas of the program materials to fit the new population. So you might be changing names of, areas that they might interact with. So it might be putting your clinic name or your community-based organization name. You might be selecting pictures that more represent their community, choosing words that are common to that particular culture or community that you're working with. Another example is color. We've worked on adaptations from white to American Indians and trying to change colors that are kind of more meaningful or represent things that, they kind of like or see. You could also change ways of recruiting or engaging the population a little bit better. So a great example of this might be knowing where to reach your community, going from one setting to another setting. How can you best recruit them? Is it flyers? Is it word of mouth? Is it sending it through a listserv? and also engaging priority population. An example of that might be incentive. An incentive for one population may not work as well as an incentive for another population. So when you're trying to understand the community that you want to work with, and you're doing your needs assessment, you might want to figure out what incentives might help them. Instead of being a gift card for one community, it might be actually a transportation waiver or something else that would get them to your program that would work for your new community. So those are just some example. That is our analogy of some considerations before you just go into a very critical step of making changes and considering what changes you might be able to make or not make. So let's put this into practice. What I wanted to do is give you a chance to understand an evidence-based program, and then we're going to decide if we are making an adaptation of this program from its original kind of purpose to a new community, can we make some of these changes? So this is one of the handouts that was set out before, and we can put the link into the chat for you if you want to look at the 2-page description of this program. But I'm also just going to walk you through it verbally right now. So again, this is sponsored by the Cancer Prevention Control Research Program. We just want to be able to highlight an example of, in this case, a colorectal cancer program that is evidence-based. So this program is called the FIT Flu Program. It was designed to help adults increase their colorectal cancer screening, particularly through FOBT or FIT kits, which is one test that you could have that is an annual test to screen for colon cancer. This intervention is called FIT Flu because it actually happens in settings, pharmacy, clinical settings, where we were trying to capitalize on an opportunity where people already are doing a preventive activity of getting their annual flu shot and adding another kind of prevention message of selecting people who fall within that correct age of 50 to 75, of telling them about the one way of getting their colon cancer screening, which is the FIT test. So you will see that the audience of interest are people and patients who are coming in to either your clinic or pharmacy who are 50 to 75 years old, who are due for colorectal cancer screening and who are trying to get their flu shot at a doctor's visit. What are some of the components? The components are a nurse or medical assistant provides them with educational materials and also offers them the at-home FIT kit. And as some of you know, it's a test that is stool-based that you complete at home and then you mail in. They are given instructions for how to do it and given a video link and also an envelope for how to return the kit to the lab. The materials are available, you can see, in a variety of different language. And after the visit, it is a little bit of on the onus of the patient to actually take it home and complete the mail FIT kit. So that's an overview of the program. You have it in front of you. So let's do our quick activity of trying to apply the red to green light adaptation consideration that I just talked about. And in this example, we're trying to replicate and make slight adaptations to the FIT Flu program for use in a rural clinic. For each of these, we're going to ask you, would the adaptations in your mind be a red, yellow, or green light adaptation? And so this is going to be conducted through polls, and we're going to talk about each one just to kind of get you to think through adaptations a little bit more clearly. So our first poll is adding a logo of your hospital or clinic to your announcement and program material a red, yellow, or green light adaptation? The second one is, can we eliminate the log sheet to record who gets the flu shot and the fit kits dispensed? Is this, again, a red, yellow, or green light adaptation? The third one is, can you add a process for dropping off the fit kit if they, for some reason, don't want to mail, or if they're coming back into your facility anyway? The fourth one is, can you develop new visual materials for people with lower literacy? And the fifth one is, can you expand the participant age to a wider age range? So I'm going to give you a few minutes to think about our red to yellow light adaptation. That's another handout that you have, again, that you can refer back to. And then we'll actually talk through this adaptation. So thanks so much for participating. I know this was a quick way to kind of get you to apply the concepts. You have another minute to think about this, and we'll actually talk through your answers and then the correct answer. All right, let's talk about this, and let's see if the majority of you got it right. Adding your hospital logo to the intervention materials and announcements. 86% of you said this is a green light adaptation, and you're right. This is something that we would call more surface level, making sure that in this case that you are branding the materials so that the community kind of reflects on something that is closer to their community in terms of your hospital or your clinic. So that would be definitely a green light adaptation. Great. So the second one was eliminating the log sheet to record that they actually received the flu shot and the fit kit. And this is correct. This is a core part of the intervention, and knowing that they did receive both the flu shot and fit kit. So this would be a core component, and 73% of you are correct. For those of you in the yellow, yes, proceeding with caution is correct as well, but I would say the more correct answer is not making a change in this case at all, since that is being able to track your participants. So the next one, what about adding a process for patients to drop off the completed kit? Because as you remember, we discussed that they're supposed to, they got instructions to how to mail it back. What do you think about that? So this was a tie. So 51% of you said it would be a yellow, and then 46% said it would be a green. So in this case, we considered it a green light adaptation because it's actually still returning it. It's just another mode or another form of returning the kit. So for those 46% of you that said green, kudos to you. That's the right answer. Developing new materials or visual aids for low literacy patients. What do we have for this? So 65% of you said it was green, 27% of you said yellow, and then 8% said red. In this case, we would say yellow because of two reasons. One is that the materials actually have to be developed. You also want to make sure that the content is still science-based and conveys all the same information. So remember, we said this is where you want to proceed with caution and get more feedback. And so you want to make sure that in this case, you talk to your primary care physicians and cancer researchers to make sure that the information is still being imparted, even if it's at a lower educational level. So in this case, the yellow light would be where we would say you would want to have your adaptation. Finally, what about expanding our patient populations to those 40 instead of 50 to 75? Is this a red, yellow, or green light? And the most common answer was 59% of you, or almost 60% said it yellow, and 38% said it was red. In this case, we would actually say it's a red light change because you are in two ways changing the age population for whom the materials were developed from the original program in a big way. And two, it doesn't match the science because even with the new guidelines, they're asking for cancer screening for colon cancer starting at age 45. But at the time of the program development, it was 50 to 75. So again, I would make this change. And as you talk to providers and cancer researchers, they would say this would be a red light change as well. So thank you for playing and just applying some of the new knowledge that you gain in terms of adaptation considerations. And as you can see, that's why having a planning committee is very important and stakeholders to inform the process. The next step that we talked about is after talking about the areas of mismatching and deciding what needs to be changed, and thinking through the red to green light adaptations, then you need to make the changes. And so that's where you will look back at your fit tool that I just showed you in step 2 that you're filling out and walking through what needs to make changes, deciding who will make the changes, and throughout this process, consulting with stakeholders to help you. So going back to the tool that I talked about is once you identify areas of matches or mismatches, you need to walk through, can you actually make those changes? And this is just a quick graphic of that in terms of applying it to a systematic process. And you could actually document your reasons for changing or not changing, as we talked about this. Many of your planning committee considers this a red light, adaptation. So you're not making the changes, or of course, changing the population or some of the content is much more green or yellow light, and you will make those changes. In terms of experts to help you with decision making, these are some that we get you to think about. These might be the actual developers of the evidence-based interventions. Actually, with some of my work and helping communities adopt evidence-based interventions, we have actually emailed and talked to the original developers. And sometimes they actually have developed adaptation guidance that may not have been with the original articles and things like that, or haven't been shared before. And so that's very helpful. Also, content experts of the disease topic are helpful because they're going to be knowing what is the science and the evidence and what should be said. Obviously, we would like to have community members at the table, and maybe they're the ones that can help you through an adaptation process of getting interviews or focus groups and letting them look through the materials or adaptation success suggestions, and they give you some insights into that process. And then another critical stakeholder we get you to think about is the organization implementing the adapted evidence-based interventions. They might have thoughts, of course, on delivery, implementers, and all that in terms of if you're making the adaptation, who might be the best people who are already poised or could be trained in their organization to deliver the program. So these are some examples of consultants to consider. The next thing you would want to do is to test the adaptation. So you could test the adaptation using rapid cycle quality improvement, such as the plan, do, study, act cycle. You could also have pre-tests of the adaptations through methods such as focus groups and sharing the materials. And so some of the things that you might be getting your audience and participants to consider are implementation outcomes. If you made changes, are they acceptable and appropriate to the new populations? Do they suggest any other changes to kind of make it more culturally fitting or fitting with the resources that they might have access to. And you might also be looking at some of the program outcomes, such as behavior change or environmental change, such as social support or actual changes in policies, and getting a sense of that implementation. So pre-testing adaptation is a smaller step to piloting the full adaptation. So in this case, you might be continuing to do quality improvement and fast cycle with the whole program in terms of all the adapted elements. You might be getting a small example of your target population and working with that community to actually implement the full program. And again, you can test on intervention outcomes and also acceptability outcomes, as we talked about before. So those are the 5 steps that we have truncated in terms of thinking about adaptations to kind of make it simpler to you, but still having all of the considerations from the scoping review that I talked about before. So one new area that is coming out is thinking about not only what we change, but being able to document what we change. And this actually helps us in 2 areas. One is that we can communicate when we went from a selected interventions to our adaptations, what was actually changed. And then for some of you who might be doing some dissemination, either through conferences and or reports or publications, you can actually document what adaptations you made. So typically adaptations can be planned adaptations, which is really the process that we're getting you to think about, is to be very deliberate and have a systematic step for making the adaptations. In terms of your actual delivery, you might make slight changes on the cuff, and these are called what we call kind of more reactive or unplanned adaptation. So during your implementation, you also want to measure and document any quick reactive changes that you may have made. These are unplanned. So one tool that we are going to recommend in terms of a really helpful resource in reporting adaptation is Shannon Sturman's the FRAME tool, Framework for Reporting Adaptation and Modification. It offers a lot of different categories in terms of collecting areas where adaptations are made, and then you can actually select what you actually did in terms of deciding on what was modified and why you made those changes. And as I said, this is a good way throughout your planning process to have a systematic way to document what you did. So I want to share this framework. It's a little large in terms of some of the different areas. You could certainly read about the FRAME model in this implementation science article that we've listed here. But you could see with the larger dark boxes, some of the areas that you can report on. So when did the modification or adaptation occur? In the middle, what was actually modified? At the very bottom, what were some of the reasons that you actually made some of the changes? Was it for political reason? Did you make changes because of time restraints or the structure of your organization? Did you make changes because your participants or recipients had different capacities, were different demographics, those types of things? So this is a great way for you to actually formally document something. So I kind of honed in on one area that we've been talking about today is what was actually changed. Was it the content? Was it the setting or context? They also suggested if you make changes to training or the evaluation instruments that you can document that as well. So if you say that you're making changes to context, which is the top box here, I would jump over to this box and you could actually circle or check what were the content modifications you made? And some of these we talked about before. Did you actually change the packaging of the materials? Did you add program elements? Did you depart from the intervention a little bit and add other components? So they kind of gave from their adaptation studies some of the more common ones that they saw happening in the field. So this is a great tool in terms of actually not only doing the adaptations, but actually documenting it so you can report it or share it later. Some areas that I wanted to talk about too is we often talk about adapting evidence-based package programs, but you can also adapt strategies and policies. So I wanted to talk about that in the next 2 slides. So if you think about adapting an evidence-based policy, for example, from one organization to another, these are some areas that you can think about in terms of potentially making changes. So if you are taking a smoke-free, a comprehensive smoke-free policy for one setting, such as a university, and moving it to another work site, you can borrow from the content of the original policy language. You can make changes to contexts or settings that are described in not only for the wider policy, but also the context or setting described within the policy. You might be trying to change the ways that who is working on changing the policy, which might be the implementers of the policy. In a university, it could be a committee that include administration and student health and employee health. But in an organization, it might be the benefits group with HR or administration. So some of the implementers can change. And then, of course, the process may differ for enacting the policy in each of your settings, but you can certainly make some adaptation to your new context. And then communicating a policy. Once it's enacted, you may have different communication channels to let people know that the policy is in place and that they need to abide by the policy. So those are just some areas of potential adaptations for an evidence-based policy. And then we also want to talk about adapting evidence-based strategies. For many of you who work in public health, we have a community guide to preventive services that are evidence-based strategies that are culled from systematic review, and they're ranked in terms of recommended strategies to not recommended strategies. Again, these are not packaged programs, but these are still evidence-based. So we know that client reminders are one of these. If you tell a patient that they are due for a vaccine, in this case, the COVID vaccine, or you remind them to come in for a cancer screening, a lot of the literature says that works as an effective strategy to kind of get them into clinic and doing the preventative behavior. And so the client reminder, though, can take many different forms, as we talked about before. In one clinic, we could do the reminder through a patient portal where we give them information about their age and that they're due for screening and to come in and make an appointment. In clinic B, you can also do a reminder. They may not have a very strong or active patient portal, but they may do the client reminder as a letter home to the patient that alerts them with the same type of information that they are age eligible for a preventive screening and that they are overdue, meaning that they haven't done that screening, and to please come in or set up an appointment for the actual screening. So this is just to let you know that you can also make adaptations to policies and strategies and not just evidence-based programs. So that's a summary of everything that you might want to know to kind of get started in program adaptation. We would love to get your feedback and invite you to quickly take this survey to tell us what your thoughts are about this particular module on adopting evidence-based interventions in this brief evaluation survey, and we'll also put it in the chat for you. So before we go into the Q&A, this is just a reminder of our 6 sessions for public health evidence into action. We actually have 2 more to go. The next one will be on May 14th on implementing evidence-based interventions. And then we'll end with evaluation for impact on May 28th. So I invite you now to type any questions that you have into the chat. And questions or comments about what was covered today, or questions or comments about how adaptations happen in practice.
We have a question about obtaining the recordings for the sessions. We are going to be updating the CPCRN website with all of these slides, training materials, and recordings at the end of the series. So they'll be up soon.
Yes, we will send out the answer key to the adaptation quiz to you as we send out the program materials. So thank you very much for asking about that. So I have a question about selecting or adapting evidence-based interventions from one topic to another. For example, adapting evidence-based strategies from breast or colon cancer for lung cancer screening. Yes, so Allison, a very important question. Here I might recommend that you actually look at evidence-based strategies instead of package programs. The example that I just gave about client reminders, we actually know that they have worked across cancer screening under the Community Guide to Preventive Services. Mary, can you put the link to the community guide? You might want to look and see what are the common recommended strategies for different cancers, and that might also help you have a starting place for lung cancer screening. The other thing that I would say is, if it's a newer topic area, is that you may actually have to go and find interventions yourself. And so one of the things that we start off with is to actually go and do a lit review and see if there are programs that have been developed and evaluated in terms of different programs that have been built to increase lung cancer screening. So a literature review, and also perhaps for those of you who are going to conferences such as cancer conferences, even if it hasn't been published, they might also be sharing it at conferences so that you can actually talk to the program developer and learn about a package interventions that is being tested and has positive results that way. Thank you, Mary, for sharing the community guide, because that's also a good place to start. Emily, another good question. When doing adaptation, how long does it usually take? I think this varies too, depending on how well you know your community that you're working with. Many of the adaptation process that I've seen take over a couple of months. We did a review of adaptations in the literature, and a lot of people started with conducting focus groups or other types of, I would say, primary data collection to understand their community, but also to get input on package program components, like maybe running program materials and showing it to people in a focus group asking them where they might make suggested changes. And this could be for intended participants, but also, as we talked about, the implementing organizations and deliverers. And that process, I think, can take a few months to actually do. And then they use that information to inform, as we talked about before, making the adaptation. And then some of them do additional pilot work before doing full implementation. So I would typically say 3 to 4 months, but if you have a lot of communities that you're working with and wanting to do more kind of primary data collection or formative work, it could take 3 to 6 months, I think, to do it well and not be too rushed. So I don't know, Emily, if that helps.
That helps a lot. Thank you.
Thank you very much for attending and giving an hour of your day with us to learn about evidence-based practice. We look forward to seeing you at the next presentation.